Alright, so with these, weight gain only for type 2 diabetes. Doesn't work for, stimulates the pancreas, so if you try to do it when you don't have pancreas doesn't work, then it's no good. Glutamides are very similar, they work very similarly. So kind of the same concepts, like don't give them to type 1 diabetics, it isn't gonna do anything. And with sulfonylureas, if you skip a meal, skip the dose, because you don't want to have no glucose or no carbs going into your body if we're lowering your blood sugar. And Alyssa, if you have anything to add, being a diabetic person, not a diabetic person, a diabetic knowledgeable person, it's a person with diabetes knowledge, please add in. Biguanides, this is one that ATI, NCLEX, this is one they really, really like. Metformin is super common. This is like the first line drug that when you're diagnosed with diabetes, they're gonna try this first, as long as you're within like an appropriate blood sugar range, A1C range, to get it. So, but it does have a lot of side effects, works pretty well. So metformin is commonly given in combination with other things, so you'll mix this with like another kind of anti-diabetic medication. You give it a couple times throughout the day. It decreases glucose absorption in the gut, so as your carb-heavy foods are going through your gut, the sugar isn't absorbed through the bloodstream as much, so your blood sugar isn't gonna skyrocket. The liver creates less glucose to release out into the bloodstream. And then it's kind of like glyphosate, it also increases your body's sensitivity. Lots of side effects with metformin, nausea and vomiting. A metallic taste is big because that's one of the things that is sometimes so bothersome to people that they will stop taking the drug. You can have vitamin deficiencies, specifically B12, because you're impacting the absorption in the gut. Lactic acidosis can occur, so your pH can go down, especially if they're taking things like, if they're drinking alcohol or they're taking cimetidine, which is one of the H2 inhibitors that we talked about last week, but that one specifically can lead to lactic acidosis along with drinking alcohol while you're on this medication. So we have to educate our patients to avoid those two things. And just because of the way it works, like it's not increasing the insulin in your body, it's just decreasing the glucose that gets absorbed into your bloodstream. When it's just metformin, you're not as prone to hypoglycemic episodes as you are with one of the other two drugs we just talked about. Big thing with metformin. So if you give, metformin can lead to kidney and liver injury. If you give metformin within, let me phrase this. When patients get contrast dye when they're getting certain scans, so if they're going to CT, you'll either put contrast dye in their IV, there's different ways that they can drink contrast dye. But if your patient is getting contrast dye, you have to hold the metformin for 24 to 48 hours before and for 48 hours after. Because if you give a patient metformin while they got that contrast dye, it's like a double dose of drugs that are toxic to the kidneys. So before we give it, if possible, we need to hold it, but we definitely need to hold it for 48 hours after, so we don't just bomb the kidneys when they're already sick because they're getting a CT. So whenever you're sending a patient to CT in the hospital, there's like a whole screening form that you have to do that asks if they've had metformin, or if they are prescribed metformin, so that it's not something that we miss and then we kill their kidneys. So gliptins, Januvia, this one you've probably seen a commercial for, commonly taken in combination with metformin. So it increases the production of incretin, I don't know if I'm saying that right, which promotes that insulin release. So insulin lowers your blood sugar, so it's promoting insulin to lower blood sugar, but it's decreasing glucagon. And we're going to talk about glucagon in a little bit, but glucagon is something that increases your blood glucose. So it increases insulin, decreases glucagon in the body. Some common symptoms: headache, joint pain, pancreatitis is a big one with these drugs. And it's just certain people, if they already have liver injury, if they already have certain issues with their body, they're more prone to the pancreatitis. So you'll see pancreatitis with a lot of the meds. Okay, we talked about insulin a little bit. in fundamentals, but that was a long time ago. So these are a lot of some slides. Insulin is probably what's gonna be hit, it's gonna be hit pretty hard on the quiz. And like the safety and how do you safely administer, what things do you need to look out for, so definitely know your insulin. For insulins, specifically the insulins, you need to know.
Yeah, all of the slides.
You know, why do you have this
Pretty
slide?
much some big.
Yeah,
all
let's
the
just
slides
do
are
the
different.
different.
Yeah.
Yeah.
They're all different.
There's this picture that
Which ones do you have? How many slides do you guys have?
35.
How many do you have?
54.
Oh my
What? Let me email it to you. When did you guys download this?
Like,
Now.
20 minutes ago.
Well, you guys did something wrong. Just kidding,
Like 20
it was-
slide difference crazy.
It was us. You don't need them.
I was like, I don't have these online recordings, and I was like, I really need these.
You don't need them.
I was like, is something something Yeah.
Okay. This is ridiculous. I updated this like on Friday too. All right, I sent it to you. Take two. Thank you. There you go. Now we can continue. It'll never happen again, guys. Now that we're done with the semester. Oh, also, you guys might have seen a couple slides, glitazones and alpha glucosidase inhibitors. I hid those because don't worry about them. I mean, if you really want to learn them, you can, but.
Advertising for you.
That's cute though.
Thank you, Taylor. You're welcome.
Is it new? Like a new color? Yeah.
Alright, here we go. Okay, there's this slide. Do we all have it up?
Yes.
Okay. I'll wait a minute.
It's okay. Tammy, there was technical difficulties.
Sorry, Tammy. Can you just delete this whole video up to this point? It's just in chaos. Okay, do we have it? Why isn't it downloading? Did some people get it downloaded?
Yes.
Okay. Please.
So maybe this is the sign, just show me what it should just say.
It's so important though. If it was like,
We can close it with the GI stuff. Just not the end.
you'll kill somebody if you don't know this stuff.
I'm just joking. That's crazy. That's crazy.
Anybody? Are we good?
That's okay.
Did you not get it?
Our Anna's in the Outlook, which is fine.
It's saying that there's like an argument about it.
So basically your internet is
Says
terrible.
that it's wrong. Sorry.
It's okay. Could be worse.
It could be worse. Okay, so know both the generic and the trade names for insulin because you're gonna hear them both in the hospital and you don't wanna confuse them because then you'll kill someone. And you'll remember from fundamentals, there's rapid, short, intermediate, and long acting. Your intermediate is your N's, your lin N. Rapid is your logs, short acting is your lins, or your drugs that end in lin. Regular insulin is considered a short acting insulin, so you just kind of need to know like everything in this row, you need to be able to identify that with that drug. So we have our onset, our peak, and our duration. So our onset is how long does it take to start working at all in the body to have any therapeutic effect. Our peak is the highest point of therapeutic effect. So at that point, we have to have a meal in our patient, preferably like within the onset time range. So our blood sugar is high enough that it doesn't tank us. So if you give a rapid acting insulin and they have to wait 2 hours to eat, they're probably gonna reach their peak and they're gonna tank before they get any carbohydrates in their body. And when I say get a meal in front of them, don't get them like a salad with vegetables. Like you have to have something with carbohydrates in them to some degree, unless their sugar is like 600, but if they just have like a 120, 150 sugar, we need to make sure that we're not taking them. You probably wouldn't do insulin if I put it in, but. So know your onset and your peak and your duration time for these. So whenever I ask you like, if you give short acting insulin, at one point do you need to have a meal in front of your patient? Is it gonna be within an hour, within 15 to 30 minutes? And it's probably gonna be like the beginning of the peak. So like if I ask about rapid acting insulin, it'll be within 30 minutes max. Does your family have like a rule of thumb? Or is it just kind of like, he takes it right before he eats and then eats?
We just say like, when we call them in there, start dosing ourselves 20 carbs is what we do.
Okay.
So we just get something going and then we dose after he eats.
After he eats. Okay. And I've had patients in the hospital, you'll do it before, but I've had a lot of patients say I do this after I eat at home. So it is kind of what if they've had diabetes for a long time, they've become accustomed to what works for them. So try as much as you can to stick on their schedule if they're still doing their normal diabetes regimen inside the hospital. In critical care, we pretty much scrapped their diabetes regimen because when you're critically ill, the cortisol and the stress hormones in your body are skyrocketing your blood sugar. So your normal dose of metformin, your normal dose of whatever usually doesn't work. And if they're that sick, they're running a high risk for having like the liver injury or the kidney injury that does not mix well with a lot of diabetes medications. So in the hospital, they might say, I usually take metformin, why are you giving me insulin? And you can kind of explain like your body's under a lot of stress, you're healing, your cortisol levels are up. So try to explain those things to them as well because they're gonna be frustrated because their regimen works and we're messing with it. And then your intermediate and long-acting insulins, you can give a dose of Lantus or Levemir, the long-acting, in the morning and have it last, in theory, 24 hours. You'll usually give, depending on how their glucose peaks and troughs, you might give 2 doses throughout, like 1 in the morning, 1 in the evening. But Lantus is pretty common. I've never given an intermediate insulin. Has your brother ever taken an intermediate?
He did way back when he first was diagnosed with shots.
And I don't know how they choose to give an intermediate versus a long acting. I'm not sure why they pick one versus the other. But long acting you're gonna see a lot more often. And it can last, in theory, it can last all day, at least 12 hours. So 1 ml of insulin is 100 units. So if you're supposed to give somebody 4 units of insulin and you give them 4 mLs of insulin, you're giving them 100 times too many. You're giving them 400 units. So you would absolutely kill your patient doing that. You will never, ever, ever, ever draw up insulin in a normal ml syringe. It will always be an insulin syringe. If you give insulin with an ml syringe, you can't measure it appropriately, you'll kill them. A unit of insulin, and a lot of you guys probably saw this in clinical if you gave insulin, it's a teeny tiny little, you can barely see 1 unit of insulin on the syringe. So just make sure, be safe, make sure you're using the right thing. So we know insulin's a hormone that treats diabetes. It's usually given sub-Q oral insulin. We can take diabetic medications like metformin orally, but you can't take insulin orally because it breaks it down in the gut and it makes it so that your body can't use it. You will use a sliding scale. So if you measure a blood glucose and it's high, the doctor will give you a scale, your history med check off, and you'll give either short-acting or regular, either rapid or short-acting insulin in response to that sliding scale based on what it says. Talked about this bit. Know the concentration. You guys might not deal with the concentration of insulin very often, but most insulin is U100, meaning 1 ml has 100 units. But there are more concentrated forms of insulin where it's double concentrated, and you don't see it very often. But if you do, you just have to be really, really careful how you draw it up. Call pharmacy, verify it because it's super dangerous. There are inhaled insulins. I've never seen them used. Have you seen them, Alyssa? Never seen them in practice, but I don't know when you'd use it. I don't know. But usually it's sub-Q. You might give it IV if you work in a critical care setting. They'll run all day long, run doses of insulin, and you'll adjust based on their blood sugar and how they're responding to it for people that have really, really high blood glucose. Here's your chart. So you can mix insulins. We learned this. Which ones can you mix? Don't look at my slide. It says.
You can't mix the L ones.
What?
You can't mix the L ones.
Yes, so you cannot mix long-acting. You can't mix Lantus and Levemir with anything. I did it. I think I told you guys this. I did it for a year, and then in report one day they were like, "Hey, we can't do this," and we're like, "Who would do that?" So it's embarrassing. But they kind of counteract each other, and you're not going to get the effect from one if you mix them. So nothing ever mixes with Levemir or Lantus. You can mix your rapid and short-acting with your NPH. And what's our order of mixing?
Cloudy.
Yeah, so which one's cloudy? What? The Humulin N. Our NPH is our cloudy. So you gotta swirl them around, and then put air into the cloudy, air into the clear, draw from the cloudy, draw from the clear. And in the hospital, you might not mix insulins much, but home health care uses it a lot. Nursing homes are gonna use it more frequently. I think probably a combination pen, injectable pen is gonna be more common, but that might be based on insurance coverage cost. You're gonna see mixing insulin if you work inside somebody's home. Also, some of you used pens in clinical. If you work in a nursing home, you used an insulin pen. Just a note about insulin pens. They should never be shared. You can take the needle off and put a new needle on, so even if you replace the needle, one pen is for one patient. That's the equivalent of changing the syringe, changing the needle on the syringe and using it for your next patient. So things can climb back up into the insulin. They probably don't, but it's a huge risk of contamination. I don't know where I saw it, maybe on a reel or something, that at a facility they were sharing they had like one insulin pen for multiple patients, but that cannot happen. So we have our logs, our fast-acting insulins. Glulazine exists, Apidra exists. I'm not gonna ask you about it. I'm gonna ask you about Humalog and Novolog. So, fast-acting gets absorbed really quickly by your subcutaneous tissue. When you hit the peak, you have to have a plate. Peaks equals plates. So if your drug has a peak, some of them don't have peaks, like they onset and then they just kind of plateau. But if your drug has a peak, you have to have a plate in front of them within that amount of time. Can last 4 to 6 hours. It's a clear, it's not the cloudy one, you know that. Usually sub-Q, you can get it in vials and pens. So that was your rapid. Your short-acting is your LINs. They'll have an R after it because that's your regular insulin. R is regular. I don't know what it's regular in comparison to, but so your LIN Rs. Oh, also, I put a like study guide / helpful hints thing on Moodle. Download it and fill it out. Use it. Fill it out while you do this. You can fill it on your own. Whatever. But it's there. I don't feel like I need to read you these things. It just has the peak and the onset and the duration. And you can read these. There's nothing new here. Have a plate in front of them within 2 to 4 hours at the very most. Or intermediate is NPH. These are often pre-mixed, but we can mix them on our own because we checked off on that. So they absorb in the subcutaneous fat a lot more slowly. They last a lot longer, like up to 12 to 14 hours. They do have peaks, so we need to make sure we're getting a plate in front of our patient. And that's kind of the difference between like an intermediate and a long-acting. Like the long-actings that last 24 hours, they don't peak. So you can give it to your patient and you don't really have to time a meal with it, but with intermediate you do. So if you give this in the morning, we need to make sure that they're eating like midday, so they don't change their blood sugar. These will be used overnight sometimes, between meals, so it's just like a slow release. They might still get regular insulin while they're using it, which is when we would mix it just to reduce the amount of pokes, reduce the amount of insulin needles that are used. And then we have Levemir and Lantus, Detamir and Glargine, I don't know. Long-acting, absorbed very slowly. It hits its onset in an hour, hour and a half, and then it just rides out for 24 hours. Like I said, you'll give one in the morning, you might give one in the evening, and this is where you're giving like 30, 40 units of this. If you're giving 30 or 40 units of regular insulin, question that a lot. This one, you'll be giving 30 units, anywhere from 10 to 50, I don't know. So that's not unusual for this one. It is unusual for regular and rapid acting. So do not confuse those two, or they'll die. So it plateaus, lasts 12 to 24 hours. It's a clear one. Happens at the same time every day. This is one, if your patient has high blood sugars overnight, the doctor will adjust that, like how much you're giving before bed. And you can't mix it. Only given sub-Q, this one's never given IV. And then there's ultra long acting, but we're just gonna skip right past that. There's pre-mixed concentrations. It decreases the risk of error, like a patient giving themselves way too much of one and not enough of the other, or dosing their Lantus number, or their intermediate number with regular insulin accidentally. So it just removes some of the error. Could be safer, but it's also gonna have extra cost along with it versus whenever you just give somebody needles in a vial. We talked about concentrations. It'll be on the vial. It's not something that you're gonna be able to miss. Like you're not gonna accidentally give somebody U400 insulin. It's not used very commonly except for people who have really, really severe diabetes, like insulin resistance beyond belief. Like my father-in-law, he's on Here's an insulin pen. You don't share them. There's a cartridge inside. You get a new needle for every use. There are going to be people out there that reuse their needles because they're probably expensive, but they shouldn't. But that's what they can afford, and that's maybe what they have to do to survive. And this is one, and diabetes is just one that, like, when people come in and they're not complying with their diabetes regimen, it's usually going to be availability of the drug. Like, they couldn't get there to get it. I mean, sometimes it can just be that they don't do what they're supposed to do, but a lot of the times it's they can't afford it, they can't get there to get it, they couldn't get in with their doctor. Like, there are so many factors that go into people being compliant or non-compliant with diabetes, that it's not a place where we can just be like, well, they don't take care of themselves, because there are so many things that go into it. There are going to be pumps, depending on your hospital policy, unit policy. You may or may not be able to use them while they're in the hospital. Don't just go ripping off somebody's Dexcom until you know you're supposed to take it off. You can turn them off. They can still continue to monitor their glucose on their phone if they want to. But that doesn't go into the computer is where the problem lies. And they don't have the same quality controls as we do in the hospital, so it's just kind of a gray area. So definitely ask the doctor if you're allowed to use them, because people who use these are they're gonna feel much safer if they can just look at their Dexcom, know what their glucose is, and know how to treat it. So with insulin, it's pretty much the same drug that the pancreas makes, so it's going to have the same effect as the drug that the pancreas makes. It promotes the storage of the glucose into the liver, and it kind of pushes the glucose back into the cells. So when we give insulin, it pushes the glucose back into the liver, back into the cells to be used rather than being in the bloodstream. While it does that, it also pushes the potassium into the cells. So you're going to have low potassium in your bloodstream. So your potassium would tank. So anytime you're giving large amounts of insulin, not necessarily with somebody who's just getting a little bit here and there, but if they're getting large amounts, if they're on an insulin drip, potassium is going to be like the highest priority electrolyte lab value next to glucose that we're going to need to monitor, because it can pretty quickly tank their serum potassium levels. Fat breakdown at the absorption site, so lipodystrophy or lipohypertrophy. So that's why we rotate sites. If you get like hardening calcification of that fat, and you're still giving injections into that same site, it's not going to absorb at the right rate. So move your spots around. If you're injecting it into a hardened area of adipose tissue, pick a different spot. Victoria, do you have a question?
I do, why does it tank the potassium like that? Is it just because they're urinating more frequently?
No, it pushes the potassium into the cells rather than in the blood. Like, keeps it from being free flowing. So your cells have potassium, so just kind of changes where it's at. Yeah. But people who are on high levels of insulin for an extended period of time, you'll have to replace that potassium quite a bit. You'll kind of constantly be chasing it.
Is that why you frequently see them like together if they're on a drip? Like
Yeah.
potassium rotation?
Yeah, you might see like potassium fluid, like a fluid with potassium, and then an insulin drip if they've had an issue with that. So we want to monitor injection sites, monitor for that lipodystrophy, lipohypertrophy, and we know we can mix them. Insulin storage. So if you're using a vial of insulin, like if it's open, it's been in use, it can stay at room temp. If it's unopened and you're not going to be using it for a while, it has to be refrigerated. The pre-mixed ones can be in the refrigerator, and with the pre-mixed ones, you want to like roll them, mix them gently. We know we don't shake them because we don't want to get those bubbles before you administer it, so it doesn't it probably doesn't going to separate, but you want to eliminate any risk of that separating. Let's skip this one. It doesn't say it's important. Okay, we're going to, so these are your GLP-1, like your Ozempic, your, what is it called, Wegovy. So these are the drugs that are made for diabetes, but they also promote weight loss, and they're used as weight loss drugs. They're a lot more common, so we're gonna be seeing a lot more complications from it. So it's gonna be used in conjunction with an oral hypoglycemic. This is the mechanism, it's confusing. It activates these receptors to stimulate the release of insulin. It makes you feel full faster. So that full feeling is what's gonna help people lose weight. It decreases their like hunger sensations. But people along with that, they're gonna have nausea, vomiting, like upset stomach, diarrhea, just kind of at risk for general GI upset because we're messing with their gastric emptying. Biggest complication that you're probably gonna see, like you can have renal failure, you can have the GI upset, but pancreatitis is one that's gonna be very common. And if you're gonna see it in acute care, they're gonna be in the hospital for something that's probably gonna be that pancreatitis. Okay, so those are our drugs that keep our blood glucose down. Now we're gonna talk about drugs to keep our blood glucose up. So, first is glucagon. You can give it IV, you can give it IM, you can give it sub-Q. Which one's gonna be fastest? Which one's gonna be fastest? IV. So giving it IV, it's gonna absorb, it's immediately in their body to increase their blood sugar. So glucagon, we talked about the hormone glucagon in the body increases blood sugar. It acts just like that. Very common to cause nausea and vomiting. So if you give it, you need to roll your patient over onto their side so that if they vomit, they don't aspirate their vomit. Like that, you push it or you administer it, roll them, and keep them on their side until after they wake up. So if you have a patient that's unconscious because their blood sugar is so low, you're going to be giving this IV. You're going to be giving it like as fast as possible to get into their body. What does your brother take with these? I mean, other than like eating carbs, does he have any like emergency medication like this?
He has, well, we have powders that like, you can feed him, but he doesn't need to swallow it, that would work. Makes sense. And then we have this, but it's actually in a nasal spray form.
Oh,
Yeah, it's called, Vaccine.
have you had to use it?
Yes.
Is it pretty quick?
It's, yeah, it like literally gives him the breath of life. Like
Wow.
he just gasps, but he like vomits everywhere.
Okay. So it really, like the vomiting is really a thing.
Yeah, we never had to use that.
Interesting.
We just
Yeah.
had to use the nasal spray.
And again, I don't know how they decide whether you give glucagon because there's other hyperglycemics that you talk about, that we're gonna talk about. But glucagon is one that you might give occasionally in the hospital. Obviously we wanna treat before it becomes very low and we can just give them some carbohydrates, give them some juice. But if they become unconscious or if it becomes low to the point that we need to get it up faster than a snack is gonna get it up, we can give a drug like this. Then we have dextrose. There's a couple different forms of dextrose. D5, and it's important to know the difference between these so that whenever the doctor wants D50, you don't give D5 or vice versa. D5 is just a little bit of dextrose mixed in with their IV fluids. So if somebody's got, like you're constantly fighting hypoglycemia, constantly giving them carbs, and you just can't keep their blood sugar up, happens a lot with older people, or like a dying patient, really sick people, their body kind of loses the ability to regulate that. You can put it in an IV fluid just so they're getting like a constant slow dose of dextrose through their IV. It's not gonna be life-saving. Like if you have somebody that's unconscious for hypoglycemia, you don't wanna give them a little bit of D5. It's not gonna work fast enough. Now D50, it comes in this giant syringe. It's literally like syrup. Like when you push it in an IV, you have to push because it's so thick and syrupy. But this will get their blood sugar up really fast. So if you have a patient who's unconscious, this is another one you're gonna give, the IV or the nasal glucagon or D50, not D5. So if you give D50, they might have you give half an amp up to 2 amps of the D50, depending how low the blood sugar is. You need to recheck it within like 15 minutes of giving it, so we know if we need to give them more. There's also, just depending on where you are, how the doctors order it, there's like hyperglycemic or gels and syrups and things that you can put like in their gums, so it just absorbs through like the mucosa, different things that they can eat. Anything else that you've seen?
Glucose tabs are really common.
Glucose tabs. Do they just chew them or do they swallow them?
They chill.
Chew them. Okay. So yeah, people especially with type 1 diabetes are gonna have something like this on hand all the time. Yeah, because you never really know when it's gonna tank, I'm sure,
We don't
for no
know
reason.
about it.
How often does he go low like that?
Like to treat it?
Yeah.
Probably like 10 or 12 times a day. Just because we keep him
Oh, like
so
he,
tight.
wow, yeah.
We'll do like one glucose tab, one like the normal spot.
Yeah.
Just to like keep him steady.
Mhm.
But, I mean, he's got a 5.2 A1C, so
Yeah, it's working.
Yeah.
How low does he get when you decide to treat him?
usually like 60.
Okay, and he feels it, I'm sure, at that point. Yeah.
Actually, he doesn't quite feel it until like 20.
You're like,
Which
okay,
is
buddy.
not helpful these days.
No, it's not helpful.
So,
Because in the hot, like if somebody gets to 20, I mean, and I'm sure his body is just used to 20. Like, but if your blood sugar or my blood sugar got down to 20, we would die. Like we aren't used to our body being like that.
and he's not looking for it after that.
Oh my gosh, that's wild. Crazy. So yeah, if your patient is showing signs of hypoglycemia or they're showing signs of a stroke, check their blood sugar. If they're hypoglycemic, especially if they're diabetic, at Lutheran we always had as needed orders for things like this. So we had like the nursing judgment to check their blood sugar, and then if it's 50 or whatever, we can give them the appropriate replacement. So if they're unconscious, we'll give them something IV. If they're awake, we either give them a snack, we give them something oral. So you just kind of have to pick what's appropriate. But obviously something oral like a glucose tab, a gel, anything is not appropriate for an unconscious patient in most cases. All right, thyroid stuff. People with hypothyroidism, we're gonna give them Synthroid, levothyroxine. You're gonna see this all the time. It's just a synthetic T3, T4. What labs? Did you talk about hypothyroidism with Nancy? Did you talk about labs a little bit? A little bit. So TSH is what? So that's our thyroid stimulating hormone. So if we have high T3 and T4, what is our TH going to be? Low. Yes. So if we have high T3 and T4, if our thyroid is secreting enough of its hormone, we don't need it doesn't need to be stimulated. So our thyroid stimulating hormone is going to be low. But if we have really low T3 and T4, our pituitary gland is working overtime, creating a whole bunch of TSH to get our thyroid to secrete more T3 and T4. So if you have someone with hypothyroidism because their thyroid isn't functioning, our TSH is going to be high or low? High. Yes. But once we treat it, we're hoping it goes down lower. So we're going to be monitoring both the T3 and the T4 along with the TSH. TSH just kind of tells us how well is our pituitary gland responding to the T3, T4 being replaced in the body. When you're giving levothyroxine, our biggest risk is going to be that you send them in the other direction and we send them into hyperthyroidism. So you need to watch, like cardiac especially is really impacted by hyperthyroidism. So watch their vital signs, watch their heart rate, their blood pressure. Do they show those like hyperactive signs? Like with hypothyroidism, we kind of slow everything down. With hyperthyroidism, we speed everything up. So we're going to be shaky, sweaty, anxious, tremors, all that. So we don't want to send our patient in the other direction. We're going to be watching labs a lot. What else we got up there? Can't take antacids with that. Can't take Carafate with that. Sucralfate. You have to take it on an empty stomach. So this will be a morning dose that's scheduled for like 6 o'clock so that you can make sure that you get it in before they have breakfast in front of them. That's a big NCLEX question that NCLEX might ask, that you cannot give, what am I trying to say? Levothyroxine with food. Will not absorb appropriately. Antidepressants can mess with it. Iron supplements can mess with it. You gotta wait 3 to 4 hours after an iron supplement for that. But the biggest thing is the food. There are a couple anti-thyroid drugs. So if you have like a thyroid tumor, thyroid cancer, and it's causing your thyroid to secrete way too much T3 and T4, you can give radioactive iodine. Your thyroid really likes to absorb iodine. So radioactive iodine will be absorbed into your thyroid and then used to treat a cancer. It's teratogenic, so you can give it to pregnant women because it's radioactive. We don't really want our babies to be in the same body with something that's radioactive in general. So both are anti-thyroid treatments. So anything that we're giving, both these, to take down our thyroid levels, teratogenic, you can give to pregnant women. Remember that. Okay, you can get growth hormones, so people that have wasting syndrome or they're just not growing at the right rate. Turner's syndrome is one where people just tend to be very small, very little bit of muscle, like very low muscle mass. You can give growth hormone to stimulate muscle growth. So obviously, before we start this treatment, we really need to monitor the weight gain, make sure they're gaining weight at an appropriate rate and they're gaining rate in general. Like, are we giving them the right dose? So with growth hormone, monitoring weight is going to be the most important thing. Growth hormone can increase your blood sugar as well. So especially kids are going to commonly get this, like kids who are just growing really slowly. So we need to monitor their blood sugar when they're on it. So monitor weight, monitor glucose. Okay, antidiuretic hormone, what do we think it does based on the name? Does it make us pee more, make us pee less? It makes us pee less, makes us hold on to fluid. ADH is another hormone, naturally occurs in our body, but if our body isn't producing enough or is producing way too much, we could have either diabetes insipidus. Did you talk about this in music class? Okay, that might be further along. You can have diabetes insipidus, which happens with brain injuries, and you just dump fluid. All of the fluid in your body gets dumped, so massive amounts of urine. We're talking like 3 liters in an hour. If you don't have enough antidiuretic hormone. So you have nothing turning down your diuresis. It could go the other way, where you have syndrome of inappropriate ADH, so SIADH, where you don't pee at all. So specifically with DI, we would give a synthetic form of growth hormone, of antidiuretic hormone. So if you're peeing a whole bunch, the antidiuretic hormone pauses it, and just kind of turns down that peeing mechanism in there. Also called desmopressin, DDAVP. We'll use them both. So with fluid balance, which electrolyte do you think is the most important? Yeah, sodium. So anytime you're messing with fluid, you're adding a whole bunch of fluid to the body, taking off a whole bunch of fluid, we need to monitor their sodium levels, their serum sodium, how much they're taking in. So if you have diabetes insipidus and you're peeing out all your water, you're retaining all that sodium. It's not a sodium issue, because we know sodium follows water. Sometimes when we get rid of sodium, we get rid of water. That's not the case with DI. So if you're peeing out all your water, retaining all your sodium, the sodium could go really high in your blood. And then if we stop it, we might have a rebound issue. So just in general, with ADH and ADH-related diseases, watch your sodium. And then the last few slides are just, maybe not the last few slides, I'm running out. So glucocorticoids and corticosteroids, we've talked about those a lot. Know the side effects. We give them for inflammation. We give them for respiratory diseases. We give it as an immune suppressant. So what are our big things that we need to look out for when we're giving corticosteroids?
Yeah, glucose levels.
Blood glucose, yep. What else?
White blood cells, because it compromises the.
Yep. So if our white blood cells are high, we can have an infection. So it sends our blood glucose sky high. Why does it do that? Stress. So what hormone? So glucocorticoids are synthetic cortisol. Cortisol is the stress hormone, and when we go, it's like the fight or flight hormone. So when we're in fight or flight, our body's going to increase our blood glucose so that we have more glucose to pull from for energy. But whenever you're just sick, your body doesn't need that. And so when you're giving glucocorticoids, we need to monitor their blood glucose and make sure that they're not at 600 because they're getting a steroid. So blood glucose, weight gain, water retention, the moon face, buffalo hump. So if you give this too much, it can push you into Cushing's. What if you are taking a glucocorticoid and then you just stop? What's it going to do to your body? Yes. So you're going to go into adrenal insufficiency because your adrenal glands are used to you taking a corticosteroid, and then you're just going to stop, and your adrenal glands aren't going to be able to catch up, and you're going to have like no cortisol in your body, which sends you into Cushing's disease. So you have to taper off of them so your adrenal glands can kind of remember how to do their job. If you just stop them, you're going to have major issues. Insomnia is another big one, big symptom. So we're going to tell our patients what? Take it in the morning if possible. Monitor your weight gain, monitor your blood sugar. You're going to be eating more because you're hungry. Your body's signaling that you're running from a bear and you need more carbohydrates. So when we talked about corticosteroids with respiratory, we have inhaled and we have oral. When do we use inhaled? Is it short term or long term? Inhaled? Inhaled is long term because the inhaled drugs don't usually go systemic, so you can take them continuously over a long period of time. Oral steroids need to be short term because if you're on them forever, you're never going to be able to get off of them. You're going to be constantly in that fight or flight state because they do go systemic. And if you are on it for a really long time, really high doses, again, and you just stop or you're just continuously on it, you're probably going to become diabetic because your glucose is continuously that high. You need more insulin to get your sugar down, and your body becomes resistant to that insulin. Here's a picture. Maybe a video. I don't want to watch it. There's a person with Cushing's, so know those symptoms. So truncal obesity, easily bruising. The moon face, so the really round cheeks, buffalo hump. The truncal obesity is having really thin arms and legs and having most of your weight being throughout the abdomen. We talked about that. Mineralocorticoids. These are just hormones. Aldosterone is one. So what drugs use aldosterone? Or what drugs impact the RAS? ACEs, ARBs, so that's just this. Has to do with fluid balance. That's what you need to know about that. Nope. There's a chart. It's helpful. Oh, well, that's it. That's all I had. Are we gonna have class tomorrow? I don't know.
Anything, listen,